Welcome back to another episode of Fourth Trimester Voices. I'm your host, Dr. Choa, and today's episode is one that every mom should hear, whether you're expecting, you're newly postpartum, or planning for a future. I'm sitting down with the incredible Dr. Agena Davenport, who is a board certified OBGYN with extensive experience in caring for women with high risk pregnancies. Not only is she a skilled and compassionate physician, but she's also a mother herself, and she brings both her clinical wisdom and her lived experience to the conversation. Today, we're going to cover everything from how to find the right OBGYN to preparing for your 6 week postpartum visit to something that's not always talked about enough, and that is how hormonal changes in the postpartum period can affect neurodivergent women or even reveal neurodivergence for the first time. So let's get into it. Welcome to the show, Dr. Davenport.
Thank you. Thanks for having me.
Of course, I just want to start from the beginning, and that is what inspired you to want to do OBGYN?
Wow. Well, I always knew I wanted to be a doctor since I was 5 years old. Didn't see any doctors that looked like me, but it was just put on my heart by God, I'm sure. And I made it to medical school by the grace of God. I started my clerkships, didn't know what I wanted to do. But when I started OBGYN, I really fell in love. I found my people. I was like, I could do this every day, for real.
Mm.
I delivered my first baby with the help of my attending physician at the time, and there wasn't a dry eye in the room, and I was hooked from there. But what I really love about the field is the depth and breadth of it all. I get to follow patients from adolescence all the way to menopause. I get to see them year after year, watch them grow and develop, talk about their children, their pets, their so I get a lot of the primary care aspect of the continuity with my patients, but I also get to do surgery. I
Wow.
also get to help bring life into the world and be a part of that very important part of people's lives. So that's really sums up what really got me into it, and what keeps me in it is being in academic medicine and helping to really shape the young minds and the next generation has been really fulfilling for me. And I really want to make sure that we are continuing to put out physicians, OBGYNs who are ready to tackle this very important field.
Yeah, I love that. There's so much assault on just birth and birthing practices and our Black mothers. And it's really, really important to have Black physicians who are passionate. I was looking at the numbers about just how many Black OBGYNs there are, how many Black female physicians, and there really isn't that many out there at all. Speak on that a little bit and just why it's important to see people like you in the field of obstetrics.
Yes, you bring up a great point. There's a big disparity in Black physicians in the United States nationwide across all specialties. OBGYN actually has a little bit better representation, honestly, of Black female providers than other surgical fields, especially. However, we still have a long way to go. We have seen since the 60s, we haven't really seen an uptick in the number of Black physicians. It's still right around 5%
Mm.
of all US physicians, which is less than half of the representation of what we represent as a whole in this country. So, really trying to improve the number of underrepresented minority physicians overall is important for many reasons. Number one, studies have shown that those patients that are cared for by physicians who are of the same race do much better. They actually have better outcomes, better compliance to recommendations, and longer lives as well.
We have to have physicians who look like the population, not just one type of person. So I want to segue a little bit and talk about your journey into motherhood. You're a mom. You have two children who I watch play outside.
Yeah.
And I just want to talk about your experience with pregnancy and postpartum and how this has changed or shaped the way that you take care of patients.
Yeah, so I think I talked to a lot of my colleagues too who are OBGYNs who are mothers specifically or parents. It's different. It's different before and after you become a mother. So in my case, I have been a mother my entire time of being an OBGYN. So a little backstory on me, I pregnant my fourth year of medical school, and I delivered my first child 17 years ago almost.
Wow.
In July of my intern year. So those of you out there who know what intern year is, it's your first year of residency. And it was a really difficult time. I definitely was dealing with a lot of transitions all at the same time, moving to a new city. Well, I was in the same city, my husband moving to a new city, buying a new home, starting residency, and then delivering my baby 3 weeks into my
Mm.
first year of residency. So off the bat, I already had imposter syndrome as the only one of two Black physicians in that training program
Mm.
out of 28, and also a mother, which none of my other classmates were. So I was coming in 6 weeks out and then starting from scratch. So it was a very difficult transition. We had no family in Ohio. I was a new wife. It was just a lot. And so that in and of itself could throw you into a spiral. But a year later, it took a whole year
Mm.
because I didn't have time to really get the help that I needed. A year later, I realized I was still suffering with postpartum depression, clinically depressed, was formally diagnosed, started on medication, and kind of went back and forth off and on medication, treating myself, which I should have been more diligent with following up. But residency then, especially more so than now, didn't really afford a lot of time for our own care, doctor's appointments, and you didn't want to let your team down, and so you went to work regardless. There was no mental health days. That was not a thing that we really talked about then. So I think going through that process and struggling with breastfeeding and feeling like, oh my gosh, I'm doing everything wrong, and sobbing when I had to go back to work. All of these things helped me be more compassionate towards my patients and understanding and be able to give them a voice like you're not alone. This is hard, but I can promise you it gets better. It gets better, and each day that you're at work and missing your baby, it does get a little better and better. And what I used to tell myself is, this hurts me more than my baby right now, you know? He's fed, he's happy. He doesn't realize I'm gone. When the time matters most, I will be there more. And that's what really got me through.
Do you think that there were moments in your journey that sort of shifted your perspective on what moms really need, right? I mean, there is sort of the what we think moms needs, but then there's like the actuality when you've been through it and you've lived through that. How do you talk to your patients knowing that like you don't think you need this thing, but you need this thing? Just walk me through that a little bit.
Yes, I mean, sometimes patients will say, "Oh, I don't want my family to come in town the first week or two. I just want me and hubby to like figure things out." And I'm like, I get you, but you may want to consider having at least one extra adult in the house because I think what most aren't really prepared for
Mm.
is the sleep deprivation and really caring for a tiny human while caring for yourself is very hard. So having an extra set of hands just to give you a moment to take a shower, give you a moment to meditate, give you help cook so that you can eat, so that you can be present and available and making and lactating if that's what you choose to do. And all of those things I think is really important. If you have a village, really it's the time to lean in.
Yeah.
You have to do it all. And I think this country really has it wrong. A lot of other cultures across the world, that is given.
Mm.
Like your family is your rock. You lean on them, they support you, you support them in times of need, and it really takes a village. So I would really encourage people if they have the help to really lean into that.
Do you have these conversations sometime in their third trimester? Because I find that once women deliver, it's like there's nothing that's entering that brain. It's just a blur. And so, at what point in their third trimester are you having these important decisions about planning for the postpartum period?
Definitely towards like mid third trimester, I would say 32 to 34 weeks, I usually start talking to them about What's your feeding plan for your baby? What are you working? And if you are working, what is your plan on entering back into work or and when? And what does your support look like at home? What are your resources like? Really trying to get them to start thinking about it. And a lot of my patients are quite on that vein of really thinking about it already. But
Mhm.
it does help to hear from your provider, like, here are some things that I think might help, and kind of try to walk you through that, especially when it's your first. And I have some moms who are like, they've had a baby before, but it's been 18 years. So it's
Right.
their first again, right? Society has changed, life has changed. Oh my gosh, the baby carriers and the strollers, everything is so like nice and new and different, and there's so many other things to think about now and safety gadgets. So yeah, I just really tailor it to what I think the patient needs at the time.
Great. I love that. So, part of my show is I really like to highlight the fourth trimester and why women need to plan for it. And I do it because I feel like I was caught off guard. And a lot of times within that 6 week period after I gave birth, I don't know if it was like, I thought it was normal to suffer in silence. I didn't necessarily reach out for the help. I didn't know where to get the help. And so I find that because of the way society has set up this 6 week visit, right? You give birth and then you go back to see your doctor for follow up at 6 weeks. I find that women don't know what to do within that 6 week period. And they're just sort of waiting to see their doctor and they're suffering alone. And I don't know the why the 6 week is a magical number. How did us as a society say at 6 weeks, that's when you're going to see a doctor? And how do moms get out of that mindset where it's like you actually can reach out sooner? Talk about that a little bit.
Yeah, so the 6 week visit, honestly, I would have to look that up. I'm not sure when and where. It's definitely patriarchal, I'm sure.
Right.
It's,
Go back
it's
to work. Get ready to
Yeah,
go
because
back to
I'm
work.
like, 6 weeks is that's when you're almost starting to feel like a person again, like you're getting a little bit of yourself back. But I like that you emphasize the fourth trimester. The fourth trimester is not just 6 weeks, it's at least 3 weeks. I mean, 3 months after
Right.
birth. And so really looking at pregnancy and postpartum as a continuum, you don't just have a baby and then go back to normal homeostasis. Like
Right, just like that.
there's no snapback, no matter what people tell you, right? And so specifically in the mental health part of it all, the first 2 weeks are the most intense. And I really want to highlight that. So in our practice, with patients who have a history of mood disorder,
Mhm.
either even if it wasn't during pregnancy and it's been well controlled for years, but if you have a history of mood disorder, especially on meds or anything like that, we do a 2 week check-in. If
Good.
you have a high risk pregnancy, meaning you have preeclampsia, diabetes, high blood pressure, anything like that, we
Mhm.
also have them on the radar to come in sooner. And so the 6 weeks probably has something to do with access. We know it's harder and harder to get into your OBGYN. And also, it's the payment structure.
Right.
It's really unfortunate that OB care is bundled. A lot of patients don't know this, and so they're like, "Oh, my doctor wants me to have a C-section because they'll get paid more."
Mhm.
False. Okay, I want to clear that up right now. Not true. Your delivery and your prenatal care is all bundled,
Wow.
and postpartum. And it's only the insurers only allow a certain amount. Now, ACOG has lobbied and we're trying to fix this, but there's only a certain number of visits that are actually covered in that bundle, right? And so that 6 week postpartum visit, that's what it is. And so bringing you back sooner, that's an additional visit, and then bringing you back again after is an additional visit. But we feel it's very important, and we even do like a nurse visit for our high risk blood pressure patients who are monitoring their blood pressures at home. They come in at 1 week, see the nurse, and then the nurse does a full assessment. If there's any concern, they call the GYN or OB physician on call,
Mhm.
and then we either draw labs, admit them, do whatever we need to do. And so that gives us another touch point as well.
One of the things that I think about is that our government may be delayed in some of these initiatives, and people are lobbying for increased access, lobbying for extending Medicaid coverage past the 3 months to a year postpartum. There's like so much happening out there, but everything is so delayed, and it really is dependent upon who is in office. And without getting into politics, how can moms really advocate for themselves, their whole health, physical, mental, emotional well-being, when insurance companies may not necessarily be at the forefront of advocating for them, and our systems may not be for them, or our government may not necessarily be for them? How do moms take control of their health and advocate for themselves?
I would say going back to a statement you made before, don't suffer in silence.
Mm,
Speak up because what you're experiencing, whether you think it's normal or it's just in my head or not, if you don't say something, then nothing can be done, right? So that's the first step. And it's not putting the shame or anything or blame on the mother. I did the same thing.
mm,
I struggled, really, really struggled with breastfeeding, and it was actually an oversupply issue. And I didn't realize, okay, my baby was popping off and crying because it was too forceful for what he could handle at the time. And at the time, lactation support wasn't as great as 17 years ago. And I reached out to La Leche League, and
mhm,
they really helped me over the phone realize that that was the issue. And they were like, okay, why don't you pump for a few weeks? But as his mouth gets bigger and he's bigger, he'll be able to accept. And it worked out beautifully. And so, like, things like that. But I would say the most important thing is to speak up and speak out if you're having any issues. Even if you only have that 6 week visit scheduled because you're considered quote unquote low risk,
mm,
you can always come in before that. You can always send a message through the electronic system that you have to your physician, to your nurses to be like, hey, this is what I'm experiencing. Is there anything you would suggest?
mm,
What should I be doing? I also want women to be empowered to really speak up to the warning signs of cardiovascular disease. So cardiovascular diagnoses are really the
yeah.
top cause of maternal mortality. And when we talk about maternal mortality, that's not just in the pregnancy period, it's in the postpartum period up to a whole year. So that brings you back to we need expanded Medicaid coverage. So a whole year after birth, those maternal mortality statistics, that's all included
Mm,
as all-cause mortality. And so cardiovascular screening is so important. So here in the state of Georgia, the Georgia GAP QC, or Georgia Perinatal Quality Coalition has created something called PEACH, and it basically gives patients a list of things that they need to look out for. And we give our patients
great.
this card too: palpitations, edema, chest pain, of course, elevated heart rate. So things like that, you take that with you to your physician. And you need to say, I am concerned about my heart. Like sometimes you just got to be like, this is my
Right, use
concern.
the
To
language.
really, yes, because even in non-pregnant and non-postpartum women, you know this, Dr. Choa, chest pain and heart attacks,
Hmm.
they present differently in us. And
Yes.
so we often get dismissed,
Hmm.
especially in the Black community. We often are like, oh, it's heartburn, go home, or whatever it is. And so it is vitally important to say, my doctor warned me about these signs. I
Right.
just had a baby and I'm worried I could have a cardiac condition. So it's very important to let your ER know
Mm.
I recently had a baby,
Mm.
because that will bring up a different alarm too.
I love that because there is language that we have to say, particularly as Black women. I get working in the ER, I see all sorts of moms and postpartum patients, but sometimes I'll get moms who will just say, I don't feel good or something doesn't feel right. Now, as a Black woman, right, that resonates with me. So I'm going to go that extra step forward. But you may get somebody in your ER, depending on where you are. You may be in rural Georgia where there is no obstetrician on call. You may be somewhere where there isn't a major hospital nearby, and you're now going in to ask for care and telling someone, I don't feel good doesn't mean anything to that person. And so practicing the language of saying, my doctor told me this is what I should be worried about. I'm worried about my heart. I just gave a baby. I feel like I'm going to die. I mean, you have to use the language so that an alert goes up. Otherwise, unfortunately, we are constantly dismissed.
Mhm. Exactly, exactly. And this has been an amazing organization to be a part of. But I think October, I joined with other birth workers across Georgia, as well as family medicine, emergency medicine, residency program directors, and doulas, and just a lot of people around the state. We all met up at Chateau Alon in October and had a big summit to really start this difficult work of really trying to turn the tide. Like this is a crisis. This is an emergency. Like women should not be dying from preventable causes this day and age. Like we have the resources. And so I really do feel like we have to start listening to our patients. Like that is the biggest thing. And asking the right questions because a lot of patients don't have that language, don't have an advocate for them, and they're just like, okay, and then they turn around and then something bad happens. So I think it is vitally important to really give our patients power.
Mm. Absolutely. That education, that advocacy, that empowering is very important. And I love that there's a summit that involves all these people because we know, right, in parts of the state, there may not be an obstetrician, right? Some people may not have access to a doula. So, how can we as a community, including ER physicians, because many of the times they're going to see these women, depending on where.
Right.
Right. They're the first ones to see these women. They have to transfer them to a hospital with an OB. And so it's not just obstetricians, it's not just doulas. We can't just be in these silos. It's everybody who is going to be the first at seeing these women and making sure that we're aware of the signs and we're able to advocate or teach them how to advocate for themselves.
Yes, they've even gone so far as to make little cards for patients to carry to
I
have
love
them
it.
on them that say, hi, I was recently pregnant. I'm worried about my heart. You may want to consider ordering these things.
I
Like
love
if
that.
that, especially in these rural communities, because then that would make the physician, I know I would, I'd pause. I'd be like, oh, let me back
Right.
up and think about this.
Right. Absolutely. And because sometimes you don't know, right? As ER physicians, everybody's trained differently. And so, one thing when I moved to Georgia, I started seeing a lot of kidney failure patients and HIV/AIDS patients, so patients with very low CD4 counts. And I was seeing things I had never seen in my training before. And so I had to keep an open mind and then be like, wow, I did not know this because I've never been exposed. And so there's going to be ER physicians who may not know. And so seeing a card, they'll be like, oh, maybe I should order this thing because I just didn't know because they don't take care of those patients all the time.
Exactly.
I want to transition a little bit because I know you have expertise in a lot of high risk pregnancies. And one of the things that you mentioned when we did an intake was just talking about postpartum hormonal changes in neurodivergent women. And I think this is such an important and powerful conversation because nobody talks about this at all.
Right.
And so I just love that you put that on a piece of paper because I think this is a group of women who are underserved. And talk to me about why this is such a passion for you and why you feel that this needs to have a voice.
Well, yes, thank you. I am a big proponent of talking about neurodivergence, and it's really kind of still new for me over the past few years because I was recently diagnosed.
Wow.
And so, being diagnosed as an adult, I have done a lot of research. I have been listening to podcasts, I've been talking to others. I've presented on the national stage for SNMA, our Student National Medical Association, on neurodivergence in medical trainees and physicians because it's something that's not talked about enough, especially in our community as Black physicians. And I felt really alone when I was first diagnosed. I felt almost ashamed. I went through a period of grief and kind of feeling like, okay, now I have an answer for this, and kind of grieving the life that I could have had, if that makes sense. Like maybe school wouldn't have been as difficult if I had known this, or maybe I could have navigated things differently. But what I've come to learn is really neurodivergence is, or ADHD in particular, is really coming out a lot in the media. And there's also a lot of people who are like, oh, everybody thinks they're ADD. Everybody had, but it is a true diagnosis. I went through full neuropsychological testing for it. So there's that. But what I'm finding more and more is the hormonal fluctuations that we go through as women really, really influences how we show up
Mm,
in that space, as well as in mood disorders, depression, anxiety. Think about it. When we talk about PMS,
mm,
premenstrual syndrome, you feel so moody, you're irritable, everything is like on 10 and your emotions are all over the place.
right.
That's because of that drop in estrogen and progesterone right before your period starts. And what we're not talking about as much, and what I'm glad is starting to happen more, is talking about transitions throughout our life as women and the hormones, as far as the perimenopausal phase, not just menopause,
Mm,
but this perimenopausal phase, which can start as early as the late 30s for some people,
mm,
but very commonly in the 40s. And so what you find is a lot of my patients come to me and like, Doc, I don't know what's going on, but I feel like I can't hold things in my head the way I used to. Like I used to be sharp. My job is getting more difficult. I can't write. I can't like focus the way I used to. I start doing one task and something else comes up. And I think it's multiple things at play, right? It's not just the hormones, but it's also look at what a lot of us are doing as busy moms, right? We have growing children, we have aging parents, we have partners, we have friends, we have a lot of different and maybe church organizations and other things that we do, volunteerism. There are so many different things pulling us at such a critical point of life, while also our hormones are also against us a little bit,
right.
right? And so really trying to get back to, well, what is normal and what can we do about the things that we deem as normal, but really maybe we can help you with that. And so that is really a new passion of mine, is really to just get the word out there. There is help. There are things that we can do, and the research is like just on the surface. There's a lot more research to do to really understand the hormones. Because in my training, in most OBGYN training, traditionally, I would say when a patient, I'm not gonna lie, when a patient comes in and it's like, I think it's my hormones. Can you check my hormones? There's an eye roll in our heads. And I think the big reason is we're not taught well how to treat it. And
Mm,
so we want to, well, the reason I love my field is because a lot of what I do, I can help fix. You have
right.
fibroids, I can do surgery. You have heavy periods, I can help with medication, or we can talk about holistic strategies
Right.
like acupuncture and different type of supplements. But when it comes to, I just feel like it's my hormones. It's kind of like that je ne sais quoi, like what you were saying before. I just don't feel right. It's hard for physicians to really get to the bottom of that, especially in a 15-minute visit.
Right. I know. I hate it so
You
much.
feel like it's a lot.
I
And
hate
I'm
that
sure
so
that's
much.
another reason why you started your concierge business, which I think is
Absolutely.
lovely because patients need more time.
They do.
My patients are like, they'll be waiting maybe an hour to see me in the waiting room. But then when they come to see me, they're not upset. And I'm always amazed because I'm like, I
Right.
know I'd be upset. I got things to do,
Right.
because they know they're going to get the time. And unfortunately, it's at the sacrifice of my own time and theirs, but I want to make sure they get what they need before they leave the office. And it's really hard in the constraints that we currently have.
I love that. I think that I'm even thinking triggered because I'm thinking about my own postpartum journey and growing up and really feeling like I'm somehow, I haven't been tested yet, girl.